COVID-19 by Madden Fulchand, A Historical Perspective. My name is Marcia Spence, and I'm the director of Marcia M. Publishing House and MMS Academy. And I've had the privilege of working with Madden on this amazing educational book. So I'm just going to tell you a bit about Madden. Madden has published two books actually. His first one was Surviving Racism some years ago. And this recent book is about racism, NHS, and COVID-19. So I'm just going to read you something about Madden. Okay. So Madden Fulchand, otherwise known as Navin, is hails from Mauritius. He started his NHS career in September 1971 in deep rural Scotland. He later trained as a mental health nurse and worked in the Midlands as a charge nurse, a tutor, and lecturer at the University of West Midlands. He obtained a Bachelor of Science degree in nursing studies and a master's degree in educational studies in 1998. While a lecturer, he led several modules in the field of health and race at various academic levels. He was appointed as a Mental Health Act Commissioner and visited patients in mental hospitals for over 10 years. Other roles before and after his retirement include being an active health campaigner, both as a group and as an individual. So he was part of Health Watch and later as an individual. He has written numerous articles and published his memoir, Surviving Racism in the NHS. And this is his second book, which is a historical perspective and a very, very engaging and educational book. And so now I'm going to introduce to you, well, here he is, Madden, and I'm now going to invite Madden. Let me check. I'm going to invite Madden to tell you what it's all about, really. So, Madden, welcome.
Thank you. Can you hear me now?
Yes.
Yes. Okay. This is this book has been a long time in the making. Although I wrote it after or during COVID time, the background of this book and the book before started a long time before that. As you make reference there, that I was a lecturer at University of Wolverhampton and did all this work in education field. When I started working in deep rural Ayrshire, it was a very sort of what we call working class environment. And what struck me early in 71, when I was very young then, 21 years old, there was a lot of people who were there with chronic bronchitis, pneumonia, chronic obstructive airways disease, high blood pressure, cardiovascular problem, backache, hip ache, you name it. And that was a direct result of them working in the mines.
Mm,
And that was actually started me thinking about inequalities in health generally. And that was part of my expertise in teaching and also in the clinical field, where you see most people who are working class who are experiencing physical health as well as mental health issues. I think that was a seed that was in my head, but I didn't know it was there till 10, 15, 20 years later. But what was happening with these poor working class Scottish miners, where the dad worked in a mine, the grandfather worked in a mine, the son is likely to work in a mine, in the mines. And that was the spark that sort of, and most of these men, mostly men, died at the age of 50, 55 before they got their pension. And those who did not die had a very poor quality of life. So, and they had a very low quality of life because they couldn't walk, they couldn't do much with themselves, they just sort of stayed home. But having said all that, what was struck me also in a different way, although the poor white Scottish working class people, they had this notion in their head, it was very consolidated in their head, that although they were poor, they were working class, they were minors, they were better than black and Asian people who worked in the hospital. There was no confusion about that. And that manifested itself in terms of how patients abused you or me, um, as in 1971, 72. I mean, they knew that they could do it. They could do it without any impunity at all. So that was the start of my journey in a hospital setting. It was a general hospital. So then I moved to but the problem there also, there was another issue which links into the book, and a lot of literature supports that, is I was training as a nurse, but I was training as a state enrolled nurse. Although I had the qualifications to become a state registered nurse, I didn't get a place, and quite a few of the people there from overseas didn't get a place to do the registered nurse training. The reason was simple. The director of nursing education told us your qualifications inferior to those qualifications in Scotland. Okay, so that was that. Now, so we didn't go to the register, so I didn't get there, and many people didn't get there. So the state enrolled nurse is basically the bedside nurse, the nurse that does your work day in, day out. There's no prospect of any promotion. You barely get any training, and they are basically doing all the work. Most of the ward managers were white, and in fact, there's a group of women who used to say to us, "Oh, you're too clever for this. You need to be a registered nurse." And they knew it because they didn't have any qualifications. We had 4 or 5 GCSEs, I used to call them then. So that is experience of racism there, because patients abuse and the director of nursing is telling you the qualifications are inferior. So the patient was telling you, and the patient was telling you, call you, all sorts of racist names. That's an illustration of direct racism. The director of nursing telling you that your qualification is inferior is a manifestation of institutional racism. So that was early 1972. I experienced all that. So and he moves on from there. I mean, when I tried to leave, left after the course was 2-year course, the enrolled nurse course, and before I finished the course, I started to apply to all sorts of hospitals to become a registered general nurse as an RGN, general nurse. I have applied to about 15 or 20 hospitals. I didn't get one offer for the general nursing training. At the same time, I applied to 15 or 10 or 15 mental health nurse training. I got about 10 offers. It just tell you the difference in terms of where we were being sidelined to mental health rather than general nurse training. And that was the start of my journey. And it gave me a very, very different perspective about the NHS itself. So do you want me to stop here or continue, or?
I think now you've introduced yourself. you could tell us about the book and the whole context. You've got like 20 minutes to deliver. So we're going to have a bit of a lecture from you, and then we're going to start the discussion.
Okay,
All right. So I think,
okay, that's fine.
yeah.
Okay, my lecturing days was in mental health, but I also had a branch in other issues, teaching research. But my fascination was about inequalities in health. When I did my degree in 1948, 1940, 1984 to 88, that was constantly on my head. There was few books I wrote, I read. The Black Report for those who are in the health service, Health Divide, HSN Report, and all sorts of reports. They actually talked about inequalities in health. They talked about inequalities in health in terms of how people who are of working class background has poor access to health and how they got less favorable treatment and how they're more likely to be in need of health. There was talk about age. If you look at, even now, if you look at some of the posters in the NHS or in doctor's surgery, they say to you, you can have a blood test or whatever test from age of whatever it is to 74. After 74, you have to ask to have a particular like annual MOT. You have to have You have to request. The emphasis is on you. That in a state of when we are 74, they don't want to know basically. So you have to take the initiative. And also in terms of women, inequalities in health, in terms of midwifery and all of these other issues in terms of access to health. But then we haven't even talked about race yet. This is what it is. It's a structural inequality that was built in to society. The British society is structured in terms of age, gender, race and ethnicity, age. And if you want to add LGBTQ on that, that's the other element of it. So structural inequality is actually built in to every aspect of British life, from education to health to judiciary to all sorts of employment, etc. So it spreads across the whole spectrum of British society. So when when I was a mental health commissioner, you mentioned there, Marcia, I visited hospitals where patients who were mentally ill were detained under the Act, which means they had no choice to be there. And there was no question about it. There were a couple of explicit examples. It will hit you in the head as you walk in. That most of them were working class people, very, very few are academics or bank managers or whatever it is. So they're all disproportionately represented in mental health. But if you look at black and minority ethnic people, they were way over represented in mental health institutions. So all these was already there. It was already there. That's a pre-COVID. The book is is structured in two parts. One is before COVID, and the second after COVID. So, I mean, when COVID came, I mean, if you want, I mean, I don't want to go through the details of how COVID was not managed properly by the government at the time. That's another book in itself. Um, the, the it doesn't, I mean, given the background I've just described, it did not surprise me at all when COVID came. It was going to impact disproportionately on working class people, regional people like north-south divide. People from in the north will had longer lockdown, more likely to be ill with COVID and the rest of it. And people who are in affluent areas were relatively better off with trying to sort of manage COVID, if you like. They weren't getting that COVID that much. Even if they did, they will have a better type of treatment than the working class people. So it didn't surprise me that black and minority people were overrepresented significantly in morbidity and mortality in terms of COVID. What was also clear, and this is part of the reason why I wrote that book. It was not only black and minority ethnic people or old people or men or regional variation where people from the north and the south have significant differences in terms of COVID-19, how much they had to wait for ventilators and how much they had to wait for um, getting treatment, and how many of these people were discharged from hospital to care homes without having the COVID-19 test. And we know about 20,000 people died in that time. So what was different with this one was during COVID-19, Black and minority ethnic.
You see, when this goes teep, teep, if you open it, then
Which one?
the chips, right? Turn the other things, then shove it back in.
What was the question? Sorry.
No, I don't think it was a question, Madden. I think someone was speaking in the background.
Oh, okay, okay, okay.
Okay, sorry.
That's okay, no problem. Okay. So what was significantly different was Black and minority ethnic nurses and doctors were overrepresented in morbidity and mortality from COVID-19. Now, why is that? Okay, you may think doctors, well, they will get a good salary, they looked after themselves, and nurses as well. There's a lot of evidence to suggest that, as in World War One and World War Two, I'll make the link here with what was happening before. In World War One and World War Two, Black and Asian soldiers were sent to the front line with rifles against the Germans, submachine guns. So there was a strong body of evidence that um, black Asian minority soldiers were sent. They used to call them cannon fodders. They used to send the Asians and the black first, and under the white leadership, of course, and then the white soldiers will come on later. So I made that link with COVID-19. The same thing happened. Most Black and minority ethnic nurses and doctors are on the front line. They do the work. In this case, with COVID-19, they were disproportionately allocated to wards where there was most sick people with COVID-19. So it was something like with allocation of work. So what actually happened when they were at work? We know COVID-19 was a very seriously infective disease which we contaminate. We can contract COVID-19 by droplets and breathing and touching and all these so ways of contracting infection. There was the big issue about PPE, personal protective equipment. Everybody who used to work in infection anywhere, you have to have proper PPE to protect you from being contaminated. So what was happening? There was a lot of issue, and during that time, I made very, very detailed notes about what was happening with daily review on the TV and what have you. So the PPE, the personal protective equipment that were being sent were not satisfactory to protect people from being contaminated. They were out of date. Many were out of date. Some were built, or not some. There was a general view that they were built on the face of a white person. So the white face model was seen as a model. Basically, if you had a beard, the PPE won't fit. If you wear head turban, the PPE won't fit. If you had a head covering, PPE won't fit. If you had beard, for religious reason, the PPE won't fit. But they were told, if, that's nurses and doctors, were saying, if you don't fit, don't use it. Yep. But the problem was there was a lack of alternatives, so they had to use it. So in the consequence was many got infected, and so quite a few doctors died. And according to the Filipino Nurses Association, 20% of their membership suffered seriously, and I mean, it's not very clear, but it looks like 20% of the nurses were sent to the front line, and they suffered quite a bit. So, I mean, I can read you on one page on my extract here on one page 156.
Yes, please.
And this is the extract from doctors BMA, British Medical Association, where GPs died. It says here, black staff, 25% make, I'll start again. Of those staff whose ethnicity could be determined, Asian workers account for 30% of those overall deaths. Black staff, 24%. Whether in the workplace, there's a lot lower than that. In September 20, the British Medical Association, BMA, in 2020 had a memorial in memory of 47 doctors who died while working during the early phase of the pandemic. And the BMA Council chair said, they are GPs and hospital doctors who treat us when we are sick, and they are our friends and colleagues who dedicated their lives in pursuit of helping us get better. The vast majority of those who sadly died are of BAME ethnicity, and many coming from overseas to contribute their valuable skills and expertise to the NHS to save lives of others, only to tragically lose their own. And the pointed message here, he added, we must never allow our BME colleagues to be taken for granted or disadvantaged. So that's the doctor version, the BMA version here in terms of what they said. What they've done. Many of them, the frontline workers, risking their lives to provide treatment and care, and PPE shortages affected frontline workers, especially during the first wave of those operating health and social care sector. So you may well say, well, okay, PPE shortages affected everybody, but there's no evidence that it does. There is evidence that managers hid PPE. There was evidence that managers locked away PPE, especially at night, where you couldn't get access to them. So that the reason for the staff who were subjected to that treatment, and many died, according to all the evidence I have. I mean, I can go on now. Do you want me to stop and take some questions, or?
Yes, you can do. I'm going to ask you a couple of questions first.
Okay.
Okay, Madden. So why did this book is a historical perspective. So I know that the book goes way back, charting, history. It talks about armies. Like you say,
Mhm.
I'm understanding what you're saying about Black and Asian people being cannon fodder, and also that, and so that connects with COVID, what happened
Yeah,
during the pandemic, because what you're saying is that in that respect, Black and Asian people were also cannon fodder because they were put
yeah.
right on the front line with the most infected or unwell people. So I'm saying two things here. I'm curious about why you had to go so far back in history, because
Okay.
how to then make the point about something that's happened in recent history.
Right. The book actually takes the historical perspective is very, very the operative word here, the historical perspective. I think the issue here is I've read so many books from nurses' perspective, doctors' perspective, in terms of morbidity and mortality and all the rest of it. Very, very few put the whole issue of the NHS in a historical context.
Mm.
they come, this person has got this disease, etc., and we go and treat them, whether we treat them because they're male, female, black, white, whatever it is. They have taken every sort of, they haven't put the whole NHS in a context, and that's the major failure of many academics. Some of them have, but they haven't gone far back
Mm.
in the way I did.
How
Because
far did you go in the book?
I went as far as 1661.
1661. So this
Yeah,
book goes from
yeah,
there and tells the history.
yeah.
Just needed to
16,
really emphasize that point.
yeah. 1661 is it's called the Barbados Slave Act.
Mm.
Okay, many people don't know that, but when I found it, I was very, very uh, shocked, angry, and all sorts of things. The Barbados Slave Act was designed to make life easier for the slaves, but it actually turned out to be the other way around.
Okay.
What it said along, just for the purpose of this discussion today, is
Yes.
black people are only good to be slaves.
Mm.
They cannot be anything else.
Mm.
And all sorts of reasons why that should be, because of their intelligence, because they have to be led by white people. If you lead them, um, if you give them too much freedom, they'll revolt, and they're not all these stereotypes you
Yes.
can think of. I mean that what was significant in the 1661 Barbados Code is codified in law
Mm.
the inferiority of black people and the superiority of white people. So that was there. And in fact, the Barbados Slave Code transferred itself to Jamaica, to North America, and the ideology spread like wildfire. And they all worked on that hypothesis. And so that was the one that I got down to. Then the other part of it is about 1555. There's an author called Peter Fryer. I would advise people to read it. He actually said there was black people in Britain before English came. Yeah, there were black people in Britain before the English came. Interesting statement. And a few years after that, they actually stated clearly there's black and Asian people who have been living in Britain since 1555. Okay? Some came as slaves, others came on their own desire. That was the issue. I mean, when I'm talking about that, there was Queen Elizabeth the First decreed that in 1578 and just around that time, 1500 and latter part of it. But there's too many black moors here. We need to get rid of them because they're taking food out of her subject's mouth. And he wrote to Lord Mayors of London, Bristol, various parts of the English um, the English parts to deport these chaps, and because for the pure reason they were taking food out of people's mouth, so they had to be deported. We know that this deportation didn't take place, but the
Mm.
numbers we're talking about here is number 10, only 10 people.
Wow. Just
Yeah.
10. Just
So
10.
you get the ideology now where it's come. I mean, if
Yeah.
somebody says to you this black anti-Asian came started last week or last year, this is documented in Queen Elizabeth the First, who actually said there's 10 black moors, she called it, or too many, we need to get rid of them. There's no record that they actually happened, but that's irrelevant. But the ideology is still here today.
Mm.
So that's the sort of the 1661 to 1500s.
Madam, can I ask
Yeah.
a question?
Yeah.
Where were the blackamoors from?
They were mostly from Africa.
Africa.
Yeah,
Oh,
and
which part?
there were interestingly good question, Marsha. There was some from
Yeah.
India.
Ah,
There were
yeah.
musicians, there were artists, there were servants, but by and large, they were brought in as a showing off to say, look, I'm a colonial person. I've had this person as my
Right.
servant. It was
Right.
as a way of sort of,
A trophy.
it was like having a gold medal of some sort. Oh, look what
Okay.
I've got. Okay.
Okay.
So there were Indian people there, man. Many of you were gifted musicians. They had all sorts of other skills as well.
All right.
Yeah.
We've
So
got
Madam,
some
that's a
questions
question.
for you,
Madam,
Madam
that's a question.
yeah,
David.
You said your book started, well, you went back from 1661.
yeah.
How far forward have you gone now, and where has the book actually stopped? Is it present date, or was it just the end of COVID-19?
It ended about 2024.
So, how would you relate this now, the COVID-19 and the NHS, to present date with, like with all the backlog of patients and the corridor care and
Mm,
all what's happening in hospitals today? How would you rate that with, like you say, black people and the ethnic minorities were the ones who were most effective with COVID,
Yeah.
and the way that the hospital numbers are now? Do you think that the hospitals are more focused on COVID? If people are coming in, are they testing them a lot more and being more stringent, or are they just more lackadaisy and just going along with
Okay.
treatment they can do?
Yeah. Well, there's a context to that I also wrote in my book. Before we got to COVID, I talked about three different aspects of health pre-COVID. One was mental health, where I worked, where black patients, Asian patients as well, were significantly overrepresented in detention. They were given extra medication, given physical treatment. They were locked in mental health secure units, and all these stereotypes about being big, black, and aggressive, and all these sort of things. That one.
mm,
The other
Mm.
one is
It was one in
maternity
four
care.
black people.
Yeah, yeah. Sorry.
There was what is like one in four black people either end up in detention or in a mental health hospital.
Yeah,
yes.
yeah. Okay. And then we have maternity case. Maternity. I followed
Mm,
the maternity issues with quite because I used to teach midwives, believe it or not, a long time ago.
mm,
And there was the issue here with we talk about now what's happening in terms of Queen Elizabeth Hospital and Shrewsbury Hospital, where women are disproportionately are dying during perinatal care. But
mm,
we've had this with black and Asian people since the 1980s.
mm,
Okay? During the 1980s, there was a lot of literature talking about how Asian women and black women were suffering, indeed dying. Black women were dying disproportionately from during childbirth and
mm,
also sometime after. Asian women were having twice as likely to die from that one. The other aspect I took up is sickle cell and hemoglobinopathies.
mm,
Okay, we know hemoglobinopathy has been affecting black community for years. Even now, there's spasmodic examples of good practice, but it's not mainstream. And how there was a chap who I referred in a book, I think 2021, he had sickle cell crises and he wanted medication. And they only gave him paracetamols or whatever else and didn't work. So he, from his own bed, he dialed 999 to
wow.
ask for oxygen.
Yeah, I remember.
Yeah.
Mm,
And the coroner made a critical remark about how can somebody go in hospital and dial 999 and this chap died. And this is so we have the last point is I'm getting to that age now. I'm 70 plus, and there's very little what you call care for old black, Asian, and minority ethnic people in the old age bracket. You'd assume that we don't get old, or if we do get old, we get looked after by our family. So there was a track record already with these four. I could mention other things. I mean, I can mention cardiovascular problems and high blood pressure problems and all these. These are four um, um, uh, illustrate case studies, as I can suggest, that already said the track record. And when COVID came, it just went right to the top of
Because
the tree.
the reason why I asked this question, because it is quite personal to me.
Okay,
Um, New Year's New Year's Day, my niece took ill, was taken to the QE hospital at
okay,
6 o'clock in the morning. It took them 16 hours to actually go to her, even though she was screaming. She was blue lighted in, and she was screaming out in pain. So I got chest pains. That between them 16 hours, somebody came, gave her morphine, and just said, "Somebody will be along to see you later." And it wasn't until she had two cardiac arrests that they then intervened and then put her in a coma.
yeah,
She lasted 24 days, and Saturday, after having pneumonia, chest infection, water on the lungs, water on the heart, a brain bleed, three more cardiac arrests. Um, Today we was told, and I don't know how because they haven't done any tests, the coroner says to her daughter, it's just one of them natural things. She
Oh,
died of a natural heart
natural death, natural causes.
died of natural causes. And I said, but how could you say that without any
Yep,
post-mortems? They're just
yeah.
trying to write it off and say, we want to put on the death certificate, died of natural causes. She's 49.
oh my goodness. Oh,
Um,
sorry to hear that, David.
I know it's
I
hard, but
mean,
it's like
thanks for
so many
sharing
things
that
are covered
personal
up, so many
anecdote. Thank
things
you.
we wasn't told or we was told afterwards. And when we ask these questions, they're saying, well, somebody will be along. We don't know. This is what
Mm.
we're doing. Oh, a consultant will be along later on. And there's so many mixed messages going on. And I'm thinking, like I said, I've linked that. And then she had sepsis and she was put on a COVID ward. But none of this was told that they tested her for COVID from day one. It
But
was
didn't tell
just,
you, didn't nobody knew this?
no. And it wasn't until Friday when my sister asked the nurse, has she got sepsis? No, she hasn't. Saturday morning, she got sepsis.
Mm.
So I was saying,
Mm,
so why did all of this link up? Is it something that you're failing to actually tell us, even though it says we've got at least 100 years of healthcare experience in our family? I
Yes.
did
mm,
30 years in the healthcare. I'm working 10 years now in the mental health sector for
Hmm.
Black and BAME people in the local community. My sister's another auxiliary nurse at another hospital. But yet they take it for granted that we don't understand that they got to try and keep these things away from us and just feed us these little breadcrumbs, and that we'll be accepting of that. And I'm
yeah.
Mm.
thinking, in today's society where you got all these people cared in the corridors, are the black community being looked over? Or
Hmm.
is it just a blanket thing that they're just treating everybody as one and not looking at the cause and the symptoms? They're just treating everybody for the same kind of thing.
Great question.
Yeah. I think there was while you were talking there, David, there's an assumption people make um, with black people, um, low pain threshold
Yeah.
or high pain threshold, whichever takes their fancy at that particular point in time. Yes, you can hold no pain, you can hold. I mean, I've heard that in midwifery for a long time. Oh, the African Caribbean is strong, so you don't need medication and that sort of things. On the other hand, is they're putting it on, or they have some relationship with drug offenses or something of that sort. I mean, all these stereotypes are coming in people's head. You don't have to explicitly say it,
Mm.
but it just depends on how people, what do you call, something that's baked into the system.
The
Is baked
unconscious
into,
bias.
yeah. I mean, it's I mean, you buy cake, there's some ingredients where you don't see it, but you taste it. I mean, this is how it works, This it's so deep-seated. And on the other hand, in terms of, we talk about equality, diversity officers and all these inclusion officers and all these sorts of things. I mean, I've challenged a lot of people about that. They cannot impact change because they're there to make the organization look better than it actually is. They have no real power The real power is about chief execs and directors and what have you. Well, on the subject, I may distract directed and just divert a little bit. If you look at the NHS boards of your trust near wherever you live, you will see CEO is white. Most of the directors are white. Yeah. And
Yeah.
and what was made very clear during COVID, when doctors, when nurses were dying, the doctors were saying, and the nurses were saying, we are not represented at the power level to make decisions that
Yeah.
is compatible with our needs. Okay? So there's a lot almost like a sort of, there's a huge chasm. Go
Mm.
back to again to this World War I, World War II. You go into work, the generals are sitting 10 miles away in their bunkers, totally detached. There's a lot of similarities with that. Um, in the way I see it. Did that answer your question?
It does, yeah.
It does. Okay, wonderful. Thank you so much, David, and thank you
Thank
for
you.
sharing and condolences to
Long
you
history.
and your family and your
Mhm.
family. Right, I'm going to invite someone who has been in a position of authority in the NHS, Alison Williams, MBE. Can you hear us, Alison?
Yes, I can. Can you
Right,
hear me?
welcome, welcome, yes, and see you. Um, Alison can tell you more about herself, but also Alison was the key reviewer of Madden's book. So I think I'm inviting you into the discussion, Alison, but also maybe to share some of your thoughts about Madden's book as well.
Okay. Do you have a question for me, or shall I just
Well, we were having a
shall I just
discussion just about people in power in the NHS and midwifery. So I don't know if you have any
Yes.
comment on that. Or
Um,
you can just give your review.
yes, in midwifery, when I was in the NHS, because I did midwifery for 33 years, or maybe longer, it was very difficult. It was very antiquated. It was during the 80s and 90s and the end of the 60s, and it was very, very underrepresented and underfinanced and under-resourced. In the NHS. And so there were quite a lot of, I mean, I think my involvement in at the Whittington and at UCH, we were probably considered one of the success stories because I made it my mission. I mean, I used to get very upset and angry when I became a sister, um, listening to the way the doctors behaved and the way the doctors treated um, midwives and the way they believed that midwifery was not a normal life event. It was only normal in retrospect. So, my determination was to prove them wrong. So we did quite a lot. With me pushing and making waves among the doctors and the midwives who were there. And I got into quite a lot of trouble because I challenged my own peers about their practices and their actual behavior and their indifference towards Black patients. And we used to have a lot of problems where the doctors didn't think very much about the Asian women and they relentlessly put them in through theater. They never looked at them individually. And so we started doing our own research and making a lot of waves about, because they used to think that the Asian women were abnormal because they were so small and the babies were so small. And so they had this ritual where as soon as they came through the door, they would put them through for cesarean section, not allowing them to labor normally. And so we had quite a lot of discussion about that and trying to say, how would you expect a woman who's barely 5 foot, to have an 8 pound baby? That's a Western European analogy. And the babies are perfectly normal at 4 and 5 pounds because it's in keeping with the size of the mother.
Yes.
Mm.
Um, you know, so things like that happen quite a lot. And I think because I was there with several like-minded midwives, we made a lot of waves, and we made sure with the development of the service itself and the policies and practices that we implemented. And we were one of the very first hospitals that from the time I became a sister and a manager, one of the first hospitals that used to write policies and practices that were research-based. So we were constantly asked to help other units who were trying to do better. So I do understand, and I do know of a lot of problems that happened within midwifery, but I was one of those strong people that made sure they didn't happen in my unit.
Mm-hmm.
And so when I read Madden's book as well, besides
Alison, just
yeah,
quickly, we can't see all of your face. That's it. That's it. We
sorry,
can
yes,
see you now.
my
Okay. Is your
phone
phone
was
falling
flipping.
down? Yeah.
Yes,
Okay. Thank
the
you.
book it's on was moving a bit. Yeah, is that better?
Much better.
Hello?
Much better. Much better.
Yes. Yes, I mean, I would like to read the review that I did for Madden's book, which I thought was exceptional. Is that all right?
Yes, that's wonderful.
Um, uh, I think the publication is a masterpiece in its content and context to the subject matter. It is an exceptionally well-written and well-referenced account of racism, the NHS, and COVID-19. I have never encountered such a comprehensive description of the various types of racism that have been experienced by the Black, Asian, and multi-ethnic groups in the NHS, especially during the COVID pandemic. I found it also personal and meaningful, as many of the examples and references to life in the NHS resonated with me. I also suffered from taunts and name calling during my training and clinical practice. And I totally agree that racism is rife and institutional, that it was rife and institutional in the NHS then, and it still exists like that today. When I embarked on reading this book, I thought it would be like reading a novel because it was highlighting the author's life around these subjects. Instead, it was very heavy reading only because it was so serious and engrossing, as the subject matter demanded the use of extensive research findings to make the arguments clear and definitive. It did not disappoint. I also admired the way the author related his own personal story as examples throughout the text. It shows the strength and resilience needed to survive such levels of pain and inhumanity. I think the attention to detail is exemplary and strongly complement the author's experience of the subject matter. I think it's essential reading for all levels of professionals within the NHS and all others who work in social services. It should also be used by teachers to educate and inform students about the facts detailed throughout the book. I was actually taken back by some of the detail and facts that I learned. It was astonishing to learn the details about the extent to which the Black soldiers in both World Wars were involved, especially the Indian soldiers. I learned the disturbing facts about the strip searching of young teenage girls as part of the Stop and Search campaign. As a Black race, we have been dehumanized throughout our existence. Yet, as the evidence in the book demonstrates, we have survived with dignity and tenacity and resilience. At the end of the book, the author has left us a list of suggested plans of action for the future, confirming and establishing the fact that racism will continue to be a lifelong struggle to be addressed on a daily basis by the BAME population. I applaud the author's vision and passion for exploring these difficult subjects. This historical perspective is very relevant in today's climate, as racism is so widespread worldwide at the cause of so much pain and anguish. Congratulations to the author for this exceptional piece of historical writing. The NHS has always been the envy of the world, so it is really important that the author has been able to explore the bigger picture within the institution. I believe this is a seminal piece of work that will have a major impact on many people's lives.
Wonderful, beautiful, beautiful, and an amazing, and it really, truly is an amazing book. And just talking with Madden is just so enlightening. It is well worth reading. You learn so much from it. We've lost Madden. He was on here 2 times. I'm just trying to see if he can join us on his phone. Madden, are you there? We seem to have lost the author. We seem to have lost the author. Okay, right. What we're going to do, we'll have a little pause. I'm going to give him a call and see how he's getting on. Because we have some more questions for Madden, don't we? So I'm just going to pause for a little while. Stay on, and I'm going to give him a call. Just a moment.
Without being labeled or, for fear of being taken off the framework. You know what I mean? So it's really a challenge.
Yeah, I mean that is part of the reason why I wrote the book itself. Because one of the things with BAME history, it's a very good example because now COVID is gone. Not many people are referring to COVID at all.
Mm-hmm.
If you notice now, every new policy that's on a mental health act reforms, with assisted dying and 10-year plan for the NHS, they have not mentioned COVID in a very systematic way. So basically, what we have to do is to write and record our history.
Okay.
That's one. The other part, which is more practical, which we can do ourselves, a lot of people who have retired from the NHS, like me, like Alison and various other people, can raise issues on behalf of the other people who cannot raise anything, because if they do, they'll have to bear the consequences.
Yes.
Yeah, so that's that. And on the other personal level is there's no reason why people who have a great interest in health issues go and attend meetings like ICS meetings, the trust board meetings, and ask awkward questions about why is it that there's underrepresentation of senior managers, and why is it that there's a lot of black and minority ethnic nurses are being disciplined and bullied and harassed like they were during COVID-19. So we can do that. But there's so many policies out there. All that needs the managers to do is to implement them. Because a lot of when in 1993 there was a very good document released called Ethnic Minority Staff in the NHS. It talked all about harassment, it talked about employment, it talked about promotion, it talked about all these sorts of things. So they need to implement that. The other thing which we can do also is to ask the trust and any other organization, not education, but what is the outcome? How do you actually evaluate the outcome of your equality diversity policies? Not review them. How do you actually evaluate them? How much what did it actually change? And how much have you achieved from last year to this year? Because like Macpherson said, monitor, evaluate the outcome of your policies.
Okay, that's a valid point.
Yeah, absolutely. Rather than just having the policy and ticking the boxes and saying we have a policy. Yeah. Wonderful, wonderful.
Thank you so much, Maiden.
Thank you so much. Madden, thank you so much. Yeah, Simone's saying good point, self-evaluation. Yeah, absolutely. They need to be able to evaluate the effectiveness of a policy and even whether a policy has become a procedure and whether that procedure has been followed. So yes, okay. Given this, anything else you want to say, Madam, given the circumstances? Oh.
Yeah, so what do I mean? The power is still off, so I can't really.
Okay. So I think we'll just shall we give a vote of thanks to everyone?
Okay, thank you.
And I think we will convene because we still have we had half an hour left, for some really rich discussion. And so we will reconvene at another date and do the second half. So we'll have a part 2.
Okay.
And it can be all discussion because I've got loads to say. Madam, thank you so much. Everyone who joined, thank you so much as well. Bye, Madam. Bye-bye.
Thank you.
Bye.
Bye. Thank you.
Well done, Madam. Thank you.
Wow.
Bye. Well done and
Yes.
thank you.
Thank
Bye.
you so much, everyone, for joining. This has been recorded and it will be shared
That was really
with you.
insightful.
All right. Thank you so much, Charity.
Thank you very
And
much.
Shelley, thanks for joining. David, thank you so much. And just, your family will be in my prayers. And just, I hope you get to the bottom of what happened with your niece. Yes, very young age. So condolences.
Hello, thank you.
Condolences. Alison, thank you for your contribution.
Thank
Shelley, thank
you.
you for being here. Simone, thank you so much, everyone. And I'll see you all again soon. All right, take care.
It was great. It was great. David, condolences. Wish you and your family the
Thank
best.
you. Yes.
Absolutely. Bye.
Okay.
Bye-bye.
Thanks,
Bye.
Marcia. Great
Bye.
hosting. Thank you.
Bye. Thank you. Bye-bye. Let me start recording again. Okay. Welcome to the online launch for Collision of Racism, NHS and COVID.